Hello, everybody, and welcome to our CHEST webinar on COVID-19 Resurgence. What's different this time? I'm Alice Gallo, and I'm going to be your moderator and host today. And we have four amazing specialists from all over the world. They're gonna talk to us about this new wave of COVID-19, and we're going to talk about if this is a new disease, if it's the same, if it's more of the same. And we're going to try to also give you some tips on how to keep treating this disease that looks like it's not going anywhere. So I'm going to ask our panelists to introduce themselves, and I'm going to go by the order I see in my screen, so no particular order here. So Thomas, would you mind going first?
Sure. Thanks for having me today. My name's Tom Valley. I'm an assistant professor at the University of Michigan in the Division of Pulmonary and Critical Care. My clinical time is spent mostly in our intensive care unit here at the university, as well as at our local veterans hospital. My research focuses on ICU admission decision-making. How do we decide which patients go to the ICU and which ones don't? As well as trying to improve the organization of intensive care units, particularly among rural hospitals.
Thank you so much for being with us. Oh, go ahead.
And then I guess you wanted to know how things are going for us right now. So, we had a surge that started probably in early April, which was, I've lost track, but I want to say maybe our third or fourth surge. And it was unique, I think, to the US in that it was a surge in the state of Michigan, but other places around the US didn't necessarily experience that same surge. I'd say overall, at this point, we've clearly plateaued and seem like things are improving.
Thank you for being here with us today. The next person I have on my screen is Sai. Would you mind going next?
Hi there. I'm Sai Praveen Harnath. I'm a pulmonary critical care doctor. I'm in Hyderabad, India, in the middle of India. It's evening. I'm at, I think, hour 14 of my workday at this point. But the surge is here right now, and I think one of the reasons why the surge makes a lot of sense and makes a lot of sense to actually talk about it is because people are being affected by it, and preparing for it would really help. I do critical care and a lot of remote critical care. I do tele-ICU for India and the United States. I'm trained in the US, moved back to India a while ago. I also am on the CHEST leadership, and so I'm on the board of regents, and also on the chair of the executive committee of the Council of Global Governors. So in that role, I've kind of been able to talk to my colleagues around the world and really find out what they're going through. And the amazing thing is that it's the same thing everywhere. And there's going to be a lot of learning that can happen, which in a way, I mean, it's a very sad situation, but I think healthcare is going to get better after this pandemic because people are really much more aware of science and they know what's happening. In India right now, we are seeing about 0.35 million cases a day, and the cumulative number of those is added up to over 20 million so far. Fortunately, the number of vaccinations is also running, pretty good. It's over 175 million people have been vaccinated. So from that standpoint, we're hoping to catch up, but it's a big country. So from that standpoint, there's a lot that's happening. So glad to be here, and thank you for the webinar, and really looking forward to learning from my colleagues from the other places.
Thank you so much for being with us today, and thank you for staying an extra hour for this. We really appreciate your expertise. Next person I have on my screen here is Stefano. Would you mind going next?
Good afternoon, Alice, and thank you for having me here in this webinar. My name is Stefano Aliberti. I'm a pulmonary physician in Milan. I'm a professor of respiratory medicine, and I'm directing a COVID-19 high dependency unit here in Milan since March 2020. And the situation is getting better since 10, 15 days here in Milan. And in Italy, I would say our third wave is going a little bit down, and because of vaccination, and we are now experiencing very few cases from the emergency room, while we have several issues with people winning from the ICU, especially for complications that we didn't see, to be honest, during the first wave. And my clinical expertise is on non-invasive ventilation and CPAP treatment of COVID-19 here in our high dependency unit. And I'm really happy to be with you this afternoon, and I'm happy to learn from you all. Thank you.
Thank you so much for being with us. And last but not least, my good friend Marina, would you mind going next?
Yes, sure. Good morning. I'm from Brazil, Porto Alegre. It's a south city in Brazil. I'm a attending physician in a university hospital. Right now, we have 100 ICU beds dedicated to COVID patients and plus 30 beds for other patients. We had our worst wave in March this year. It was the first time that here in South Brazil, we didn't have enough ICU beds, so it was really difficult. Things are better now, but still have a lot of cases, still have ICU almost plenty, but hopefully with a little room for other patients to come. I'm really happy to be here, and it's an honor.
So the rest of the webinar, we're going to just have a conversation about themes that you already brought up so far. And please feel free to speak up and share your expertise, your knowledge at any time. But I would like to start with a question, especially let's start with Sai today with this first question. You mentioned that vaccines are also coming up and people are getting more vaccinated. In this new wave, are you seeing people who were already vaccinated getting sick? And then after Sai responds, then whoever wants to go next, just please go ahead.
Sure. So I think, one of the things of vaccination has been vaccine hesitancy. And, I'm sure you know that the WHO in 2019 said that one of the top 10 global health challenges was vaccine hesitancy. And that's happened. I mean, there have been people who didn't take the vaccine, but then once the surge started happening, people were all rushing for it. But in general, it's been very unusual to see patients who are vaccinated getting infected. But there have been people who had the first shot who got infected sometime later. But universally, there's been probably literally a handful of cases who got very sick, but nobody got very sick who got vaccinated. So far, we have not seen anyone who got all the shots get very sick. We have had, I think, one or two in the ICU, but pretty much they've all made it out. It's very rare to get very sick after the second complete dose of the vaccine is completed.
That's good. Vaccines work. How about others? How about you, Stefano? Have you seen anyone like after fully vaccinated coming sick to your ICU?
Yeah. So let me tell you that the vaccination strategy here in Italy has been successful since very few weeks. So I can tell you that the most severe cases of people who got the vaccine were those who have been hospitalized very few days after the first dose. To be honest, we did not record any very severe disease in people who underwent the second vaccination, the second dose, and regardless the kind of vaccination they got. So these are, of course, some preliminary data because the exact epidemiological data we have in Italy so far. So this is more a gut feeling or a Milan experience, but makes sense to me from a pathophysiological point of view. And this is good. This is good for us.
Absolutely. Tom and Marina, did you guys have any experience after vaccine that you saw patients coming in?
Well, we did have one patient that had just got his second shot, and he was admitted in the intensive care and needed invasive mechanical ventilation. But he's doing better now, so hopefully he will be okay. what we saw is that in the first wave, we had a lot of healthcare professionals getting sick. And healthcare professionals were the first one to get vaccinated. And even though this time around we had the worst wave with a lot of my cases, we didn't have as much healthcare professional getting sick, and no case at all that patient that they got severe. So that was really a good thing.
Yeah, I think what the other panelists have discussed reflects our experiences here in the US as well. It's incredibly rare for someone who's received both doses of the vaccination to have severe disease. I had one patient who received both doses who developed severe disease and died, but that is definitely the exception to the rule. And I think that overall is reflected in kind of my two areas of practice between the Veterans Hospital and the University Hospital in terms of perhaps the impact of vaccine hesitancy. Our veteran population has an incredibly high rate of vaccination, like 80+% locally, compared to our university where the rate of vaccination is much lower. And our rates of COVID, even during this most recent surge, were incredibly low within our Veterans Hospital. I don't think we went above 5 patients with COVID at our Veterans Hospital compared to our university hospital, where we were incredibly tight for intensive care unit beds. So I think the numbers really reflect the fact that the vaccine is doing an incredible job.
Absolutely. And Tom, since I have you answered just this one, so I'm gonna start with you for the next one. Okay. I was hoping to hear from all of you. We're gonna start with Tom, but hear from all of you. Do you think, or have you observed that the type of patients are the same this time around? And like Stefano brought up, the complications, are the same or different? Reason why I'm asking is, at least here where I work, we're seeing younger patients, overall younger patients. And to be honest, the severity of the ARDS that they develop has been a little lower, to be honest with you, than what we had like November, December last year and March, February of last year. So Tom, let's start with you, and then whoever wants to go next, just please speak up.
Yeah, I think that that also reflects our practice. I think the patient population definitely seems to be younger, whether that's a reflection of the disease or a reflection of who's getting vaccinated, within the state of Michigan. And I think generally in the US, like Marina said, the healthcare workers ended up getting vaccinated first. And then after that, it was the older population. And so is this a reflection of kind of variants of COVID, or is this just a reflection of who's been vaccinated and who hasn't been vaccinated? But certainly we're seeing younger people than in the earlier surges. In terms of the severity of disease, I agree. I think the severity of disease seems to be less than before. I've always found it difficult to disentangle how much of it is true severity of illness versus just the organization of ICU care, right? Like that first surge was just absolute chaos for us, compared to now where we can actually find ICU beds and ventilators and heated high flow mechanisms for patients. So how much of it is severity of illness and how much of it is just we can actually provide the care that we want to give to patients. I find that difficult to kind of disentangle. In terms of complications, I can't, I think this is all anecdotal. I can't speak to like major differences in complications. I'm interested to hear what Stefano's seen. Anecdotally, I feel like I'm seeing more pneumothoraces more recently, but I don't know if it's just like me and the patients that we're caring for compared to kind of the original surges. But I think overall, it seems like other than the demographics being different and perhaps the severity of illness being different, overall, it feels in terms of care similar.
So Alice, if I can add something on complications, I think that I agree with Thomas about pneumothorax, and I think that Also, pneumomediastinum is something we are seeing in our daily clinical practice, and we are now evaluating risk factors for developing pneumothorax and pneumomediastinum, and we are collecting a sort of risk factors related to mechanical ventilation, but also related to prone positioning for awake non-intubated patients. Because we have this gut feeling that maybe prone position in awake patients, non-intubated, might be risk factors for pneumothorax, especially males, more males more than female. But to me, over the past few weeks, the most important complication was fungi infections. Also in the blood, and not only in the lung. And the reason why is because steroids, in comparison to the first wave, have been given in the community much more at the beginning, maybe in the wrong way, to people who were not on acute respiratory failure, and people who didn't have the need to be on steroids. And then when they come to our attention after maybe 2 weeks of intubations or 2 weeks of non-invasive ventilation, so this means 4 weeks of steroids, and maybe fungi are killing our patients because they are a little bit more immunocompromised than the first wave. So this is a big issue for us now. I don't know if this is common in other parts of the world.
We have been seeing quite a bit of pneumothoraces and pneumomediastinum, and I'm not sure why, but it's high pressures or what's actually causing it. But we've had them in non-intubated patients also. So some of my colleagues have seen that. And I think it's really worth maybe what you're doing, Stefano, would be interesting to figure out, is it something mechanical in terms of how we are doing things, or is this a biological, something else different? In terms of the patient mix, it looks like there's a lot of young people, but I know someone was looking at the spectrum. In India, though, it's hard to say because 65% plus of India is very young. So you just have a lot of young people, and most of them are not vaccinated. So is it just a phenomenon related to that? And then it's because of the variant being very transmissible, we just have a large number of people at the same time. So whether that's what's happening, and that's why it looks like young people are affected, maybe so. The other part of it, the critical care delivered also varies in different locations. So it's possible that some people are getting sicker before they can reach the full tertiary level that they require, and then they're presenting later. And a lot of people are, getting home care for a lot of things. And just as Stefano mentioned, there's a lot of rampant steroid use, and sometimes patients are doing it on their own. And so that's kind of a dangerous situation. And we are seeing a significant, I would say, a very large number of fungal infections, especially Newport, with plenty of ENT surgeons getting their 4, 5, 6 cases in a week. So it's pretty sad to just see all these young people get that. So there's a lot of, the social media works pretty actively in India, and especially in the medical community. So a lot of the groups have been sharing tips on, how do you prevent it and how do you recognize it early. So that's actually a good thing that's happened. So in terms of the population, I think the younger crowd is probably more affected, but it might just be because there's just more of them at this point.
Well, we had the same impression in Brazil that we had younger patients, but I asked a colleague of mine that takes care of our data in my hospital, and when we looked at their data, it had no different from the first wave. One thing that we had is that we had more severe patients coming right now, but I guess it's because they came later. We had patients that waited for a week in the emergency room before they could get an ICU bed. So they didn't have the same care in the emergency room that they would have in ICU. And I think that's why we saw them sicker than the first wave. And about complications, what we are seeing that's really worrisome, it's that we have more infections with resistant bacteria. So that's really something that's worrying a lot in our hospital. We are doing a lot of a task force for prevention for pneumonia-associated ventilation, but it's still something that's concerning all of us.
So sounds like we are all seeing from more of a feeling, sounds like younger patients, but we are all seeing complications. And I love the fact that Tom brought something up at the beginning. Go back to like a year from now, right? A year ago, we were like, yes, CPAP, no CPAP, yes, high flow, no high flow. And I feel like now we're like, okay, high flow, pretty safe, CPAP, pretty safe. We have enough PPE in most parts of the world right now. And we know kind of know when to intubate. That's the same as regular hypoxemic respiratory failure. And taking that segue, I would like to ask a question that we got from our audience. Are you treating, in terms of mechanical ventilation, any differently than you would treat normal ARDS? Are you taking into consideration the H and L phenotypes that we have seen all over the medical journals since COVID started, or are you doing just regular ARDS, acute hypoxemic respiratory failure management? A year and a half into this now, like Tom said, that we know more. And Stefano, maybe you could go first this time.
So Alice, let me tell you, I don't have an experience in intubated patients with COVID-19. I work in a high dependence unit, and so I can tell you about non-invasive ventilation. I can tell you about helmet CPAP. So I might start giving a perspective from a non-invasive point of view. So I think at the beginning in March 2020, we didn't know anything about this disease. So we were trying to manage these patients as we used to do with pneumococcal pneumonia. So we were using helmet CPAP with 10, 15 centimeters of water as a positive end expiratory pressure. But soon we realized that this was a completely different disease. And from that point of view, we are individualizing the positive end expiratory pressure we are using through the helmet CPAP, through a lung recruitability test. We are doing every 48, 72 hours in our patients. So we put the patient on 0 PIP and then 2.5, 5, 7.5, 10, and 12.5, recording blood gas analysis and vitals. And then we are, after this 4 hours kind of test, we are selecting the right PIP for that patient for that day and for the other 2 or 3 days. And then we are doing the same with an additional intervention we are doing, which is prone positioning on helmet CPAP. And we are testing both lung recruitment through the individualized positive end expiratory pressure through helmet CPAP, and then if they are also responders to prone positioning. And we published a couple of data about that, and we found that if you are using a gradient as an endpoint of gas exchange to evaluate lung recruitment, actually there are not a lot of patients that are responding to prone positioning. So this is really tricky because PAFI ratio is going up, but maybe PAFI ratio is not the right tool to evaluate gas exchange in hypocapnia kind of acute respiratory failure. So we tend to individualize both treatments. Lung recruitment at the beginning for helmet CPAP, and then prone positioning. And if they don't work, they don't work. We stop. We do not prone patients because we might harm them, And so this is the best way as we think we can deliver this standard of care. Then another interesting point, and Alice, I think you're gonna touch this, is timing for intubation, and we got some experience about that. And then We also learned to use high-flow nasal cannula a lot, more on weaning from NIV and CPAP rather than during an upgrade. But this is the kind of experience I can bring to the table. Unfortunately, I don't have a huge experience in intubated patients.
Unfortunately, you just dropped so many pearls. That's amazing. Thank you. And tell us more, and then we'll go back to the previous question to the other panelists. Tell us more how you use high flow to de-escalate from non-invasive. Like, what are the parameters you're using in your non-invasive to say, oh, they're ready for high flow?
Yeah. So there's no protocol published about weaning from helmet CPAP or NIV in COVID-19. So what we have learned is, and what we have learned with our respiratory physiotherapists that are key players for all of this, is that we start doing 1 hour, 2 hours in the morning on high-flow nasal cannula on CPAP. We look at the puffy ratio, we look at saturation, we look at respiratory rate, and we are increasing this time free from a helmet CPAP. And in 4, 5, 6 days, we can definitely wean, have this patient wean from helmet CPAP with an increase of high-flow nasal cannula. We measure comfort, we measure dyspnea, although these patients rarely have a strong dyspnea, this better than me. And then we prolong time free from helmet CPAP with increasing timing of high-flow nasal cannula. Usually, the time the FiO2 is the minimum to get a saturation of 95, 96, no more actually in these patients. It's fine, 97, and the flow usually is 50, 60 liters per minute, but this is comfort related, and humidity could be around 37 Celsius degrees. But all these are individualized by our respiratory physiotherapists on patient comfort. And then after 3-4 days of high-flow nasal cannula, then we wean to nasal cannula, low-flow nasal cannula. There's no right or wrong. This is what we do, and
that's fascinating. Thank you for sharing. That's amazing. Marina, I'm going to start with you. Then the next one for the same one for invasive and what you're seeing, changes in physiology. Are you guys doing anything different? And then whoever wants to go next.
I guess we changed from the beginning. We start intubating the patients too early, in my opinion. I guess mainly because we are afraid of the disease and we wanted to protect ourselves, all the health workers. So we intubated patient very early when they started to have some kind of discomfort, a little bit of hypoxia, and they were intubated. Then at some point, I guess we shifted for another extreme here. We started delaying the intubation. We said, oh, they don't have any complaints, they don't feel dyspnea, and we went for really the other extreme. And now I think we are in a good point. We saw that they are not that different from what we knew before, and that we can use the same bedside reassessment and to take the best time for intubation. So I guess we found a good point. And about invasive mechanical ventilation, that I think we always kept the same protocol that we use for all ARDS patients. We didn't really try anything new. We followed the protocol, and perhaps I guess we got more experience with prone position, but not that we did it already. But we had so many patients that I guess all the staff are really well trained. They know already. They said, yeah, this patient, nurses, physiotherapists, everybody knows that, he's going to be prone again, or that's the next step. So yeah, that's how it went for here.
Tom or Sai, whoever wants to go next.
Sure. So, I mean, honestly, we think it's just ARDS, just do the standard stuff. Uh, but unfortunately, most people are not doing the standard stuff even before the pandemic. So there's a lot of education going on in terms of low tidal volume, permissive hypercapnia, plateau pressure. The other side of it is a lot of people who don't do critical care are needing to do critical care. So in fact, Chest has some good infographics, which we'll be talking about on the other webinars on, what are the things you need to look at. And that kind of education is going on. So my biggest learning has been to bring people up to speed with mini education sessions on proning and so a lot of remote sites, we do tele-ICU. So we're actually educating remote sites on managing these patients and guiding their ventilator use that way. Since I also do it for the US, I'm also seeing the variability in terms of ARDS management in the rural settings where community physicians who didn't usually have such sick patients are needing to manage them. And it's kind of a universal phenomenon. And my biggest takeaway has been just the standard stuff works. You have to be patient. You will have complications. And because of the hyperinflammatory coagulopathy issues, a lot of unusual things have happened. I mean, people with MI and things like that, they're prone, and, where do you do the EKG? Do it on the prone side or the supine side? And, all kinds of those questions have come up. But the support structures with the physicians has been amazing. Nurses have been amazing. We don't have a large number of respiratory therapists in India. So it's actually a rarity to have respiratory therapists. So doctors and nurses double up as those. And so one of the learnings from this pandemic is that we really need more respiratory therapists to help guide. Now, oximetry has become a household word. So patients communicate with us and tell us, hey, my SATs are this much when I did an exercise oximetry, and should I go to the hospital now? So we are actually managing several patients at home and treating with steroids, etc. So I work at Apollo hospitals, and so my hospital has about 4,000 to 5,000 people around the country in home care. And it's not like they're sick people, like meaning they should be in a hospital. But because of the crunch in beds, many of them have concentrators at home and they're on steroids, they're proning at home. So all that stuff is going on. So who knows whether they already have ARDS or not until they get to the hospital. So ARDS management the principles have been very useful, and reminding people that those things work has been useful. Also reminding people on measuring the parameters on the ventilator, identifying peak pressures, that the peak pressure is not an alarm you keep silencing, it means something. So, teaching people, in fact, I have a slide in one of my talks, the monitor, the silence button is worn out and the rubber's gone. So keep pushing on it all the time. So I'll share it sometime. So we have stuff like that happening, but I think there's a lot of good that's come out. I mean, it's a terrible situation, but for healthcare, I think it's a good thing that people are recognizing how important healthcare is, and smokers are quitting, and people are wearing masks, and they're washing hands, and so it's a lot of good stuff coming out too. So.
I think in general, when we compare where we are now compared to where we came from, when I think about before intubation, I agree with what Marina said. I think we're much more tolerant of patients being on. We tend to use much more high flow nasal cannula than non-invasive ventilation in general. We don't have helmet interfaces. So it's either orofacial or nothing. And we found it to be kind of uncomfortable for people to wear orofacial interfaces for long periods of time. So we tend to use more heated high flow, and we're much more tolerant in its use. We're also more likely to do awake prone positioning than we were, early. So I think that's kind of the big change before intubation. I think once someone's intubated, like the others said, the focus is really typical ARDS management. We haven't really done anything different from that. And like Sai nicely pointed out, really the key is actually making sure we're doing what we want to be doing. I think after intubation, or kind of in the recovery phase, I think the thing that we've started to see more, and I don't know if this is just a reflection of the fact that we have the capacity now to see it, but we're seeing people with very prolonged recovery phases, people on high flow for weeks or months afterward, that perhaps in the first surge, we just didn't have the capacity to allow that to happen. But people who recover, people who maybe in that first surge, we would have just said, okay, they're not going to make it out of the hospital. now when we give them time, they're getting discharged, they're on 90% heated high flow for a month, and then they're getting discharged on 6 liters of oxygen, months down the line. But, and those are certainly exceptions, but like, those are cases that I never imagined in the first surge.
And those are cases, and I don't sharing experience, those are cases that on regular flu years, that when we just had regular flu, that we would not see, because they would either like tank pretty quickly and we could not get them to oxygenate, and maybe they were not ECMO candidates. But I agree with you. What we are seeing also is like this prolonged thing. And then all of a sudden they're like, oh, 6 liters and walking, and it's like, okay, going home, So I think that's a little different also. But I also, what I've heard as a common theme is we were all afraid because unknown is very scary, but we've gotten better, and we are doing better for our patients. And I agree with Sai. I think in 10 years from now, when we do a webinar, remember COVID, I think we're all going to conclude that we got better because of it. And I just want to make sure that it's okay if I challenge you a little bit with med treatments. Is that okay? Because we have a question from our audience. So what are you guys doing different, the same, this time around in this surge in terms of meds? And you can talk to us about anything, remdesivir, tocilizumab, or anything you're doing. We already talked a little bit about steroids, if you want to touch on steroids also. And our CHEST members did ask us about hydroxychloroquine and ivermectin. So I will bring it up. So feel free to comment on it or not. So whoever wants to start first. Let's go, Marina.
Okay, I guess, well, the first big difference that we have is really steroids. Now we use in all our ICU patients. And I was submitting a study protocol about steroids because our main question now is whether we have to, how long, and if you can use it for more time or a little bit of a higher dose. So we had some patients in the hospital, well, a lot of patients that had restarted steroids after the 10 days. That's the protocol of recovery they use in recovery. And the idea now is doing a retrospective study with this data to see if we can find anything that's then to make a randomized clinical trial, because, well, that's the main question we have in our clinical practice. We don't use hydroxychloroquine anymore, no ivermectin, and I think that's perhaps still an unanswered question, but we need a randomized trial. I think there is no room for use it out of a trial. Yeah, and for tocilizumab, unfortunately, it's too expensive. I work in a public hospital, so we don't have access. I think it would be a nice tool for selected patients, but yeah, I have no experience with it.
Just a follow-up question. Are you guys measuring inflammatory markers in Brazil?
Yes, we measure protein C. Yeah, that's the standard. For public health, that's what we have. Yes, okay. As you know, for private care hospitals, they have anything you want, but for public health, we have protein C.
Okay, thank you.
I can go next. I would say we were using remdesivir and tocilizumab in the first surge, and we're continuing to use it now. I think in the first surge, at least in the beginning, we were our own local practice kind of reluctant to use steroids. But then once the data from the recovery study came out, now dexamethasone is the standard of care for our critically ill population. In terms of other, and I'd say those are really the main drugs that we're using. I think anticoagulation use has kind of fluctuated as well. There was a lot of variation in the beginning. I think now in general, most people are just using standard prophylaxis dose of anticoagulation. Although there's been a lot of kind of debate and variation even locally in terms of what we've been doing. In terms of the other agents like ivermectin and hydroxychloroquine, we have not been using those agents, and I agree. Like I think outside of a trial, I just don't see the data to support their use.
Stefano?
So so now we are almost in line with the living guidelines published by the European Respiratory Society a few weeks ago. So the for our patients on acute respiratory failure, all of them are on steroids. All of them are on anticoagulant therapy. And then we discuss about the use of remdesivir, although my own population is a little bit too far from remdesivir use. So let me spend a couple of words about steroids. Now we are running a randomized control trial. This is a multi-center trial in Italy looking at dexamethasone 6 milligrams versus methylprednisolone 80 milligrams. Because still the right molecule, the right dosage, the right duration of therapy are still unknown. We are not sure that the recovery dexamethasone 6 milligrams works in all our patients. We have a feeling that we should individualize that on CRP or ferritin or whatever, but we don't have data so far. And so 6 milligrams of dexamethasone is standard of care because of the trial, but it doesn't work for all patients in the same. The anticoagulation therapy recommended by the ERS guidelines is important, although the guidelines cannot tell us the exact dosage. So what we are doing is what we were doing during the first wave. So we are individualizing the anticoagulation therapy according to gas exchange and according to inflammation and the dimer. So these are the three tools we are using, and we are moving from different dosage of prophylaxis up to full anticoagulation. But now we are seeing a little bit more bleeding in the second and third wave in comparison to the first wave. Maybe because people are more prone to start Clexane or whatever in the house and higher dosage in the ICU, for example. Antibiotics only if we have strong suspicion of bacterial co-infection. Otherwise, we are not starting empiric antibiotic therapy in a pure COVID-19 interstitial pneumonia. And if we have randomized control trials, these are our first choice for our patients. So we tend to enroll people in our trials. And tocilizumab should be given if steroids are not working or on top of steroids treatment in very severe patients. So we tend to give tocilizumab according to ERS guidelines in people who are already a candidate or receiving steroids. In the first wave, we were using anakinra a lot in a nice way, discussing each case with our immunologists, rheumatologists. And we had the feeling that we also published some observational data, but there are some patients that might deserve a more intense and individualized treatment with tocilizumab or anakinra or whatever. Still a lot of open questions. anticoagulation dosage, biomarkers to individualize steroids and anticoagulation. We need this data. We need this data definitely.
If I go next, I mean, we've kind of moved away from a lot of stuff we were doing, but ivermectin is widely used, and I don't think we're going to ever do a trial anymore because I think almost everybody's taking it. So what may be good is to look at the outcomes, and if you can actually do a population level trial, that would make a lot of sense, I think, because several 100,000 people have easily taken it. Many people are taking doxycycline, and I even forgot where that knowledge arose from, where the idea came from, but people are taking doxycycline. And it's almost become like a pre-printed prescription for some people because there's so many, you just click a button and send off a prescription, and they're like 10 drugs. So the big question is a lot of, I know the WHO came out yesterday or a couple of days back saying, don't use ivermectin outside the trial. The reality is it's being very widely used. I'm just going to say there's going to be a parasite-free India very soon, just because of the number of ivermectin usages. But it'll be good to really try to understand what came out of it, because it's a good population-level experiment. So some smart person out there should analyze the data. The other thing is so we have a hospital-wide. There are national groups, so a lot of doctors in this field. So we have come up with the 40th edition this week of our guidelines. So we're changing it almost like every 2 weeks. So this 40th edition now has added budesonide in the first for early stage usage. So we're actually using that. But the problem is the inhalers are out. So people are, don't know what to use. So some of them are using formoterol or fluticasone with some other combination, salmeterol. So we're going to end up seeing a lot of side effects from that because people don't realize it. At the other end of the spectrum, for the very sick ones, Tosi ran out of, we didn't have it. So people have started using itolizumab, and people have tried it. And people have also tried bevacizumab, and VEGF-D drug. Some of them are actually using that. And we have seen several patients with baricitinib after the NEJM trial. Many non-intubated patients are on baricitinib and remdesivir. So that's happening pretty widespread. Again, the drugs run out. So people are now switching to the next version of, I think it's tofacitinib or something, that sort. It's an anti-psoriasis drug. So people are actually using all those things. And everyone claims it works or doesn't work. So it's not in a trial fashion, but what I've seen work is steroids and oxygen for sure. And I think that's giving you the most bang for the buck. And then remdesivir and Tosi. Remdesivir, we're using it much, much less than what we did earlier. And we're definitely trying our best to use it in the early part and not the later part. Many patients are also using favipiravir still. And the side effects to watch are the liver function, uric acid. Again, I don't know what the outcome, but if you know, there's over 130,000 articles out on PubMed on COVID. You'll find an article which suits what you want to do. So unfortunately, that's the reality of it right now. And high quality research, it's hard to do. And I think except for the recovery trial, nothing else has been really high quality where you can say, that's what works. And it's so hard, and COVID is such an emotional thing now. People are willing to do anything. It's sad, but evidence-based medicine is hard to prescribe to people when you have 6 people all infected at home without oxygen, and they're getting advice saying try this or that, and they're willing to try this or that because it doesn't cost much and or they have access to it. So the reality is that it'd be very important for us the science is not going to be to do another big trial. It's going to be to understand what happened because people did these things. Because you're actually going to get a lot of good knowledge just by analyzing what happened to people when they did these things. So I think that's the direction to go, because it's going to be very difficult to go test a new drug out at this point. So every day we're getting new drugs. So yesterday, the Indian government authorized a drug called 2DG, which is a form of glucose. And I still haven't figured out exactly how it works, but it's going to be available very soon. So there's a lot of new things out there, and part of it is because people want something to fix it, and they're willing to take it if it's not too high risk. But evidence-based at tertiary centers, we're only doing oxygen, steroids, remdesivir, tocilizumab, baricitinib, and then everything else depending on what happens. There have people who tried stem cells too, by the way. So there are many people, there's a study out of Miami that came out, which spread on WhatsApp like wildfire, and people started using stem cells. So I think we just have to analyze what happened and keep teaching people the basics of, do no harm first, and make sure that your hands are clean, wash your hands, and prevent those MDR infections which are preventable. And those will save lives more than pretty much anything else, because most people get well without doing anything.
I think one of the things that's been frustrating for me more recently is like some populations, some people have vaccine hesitancy, but then when like for instance, I can think of an outpatient that I take care of who absolutely refused to get the COVID vaccination, but then once she did get COVID, she wanted to be first in line for all these untreated, untested, hydroxychloroquine, all these things. So it's just frustrating when we know the vaccine works and can not only prevent COVID, but can also prevent severe disease and prevent death. But some people are reluctant to get the vaccine, but then not reluctant to try all these things that are untested.
We're seeing a lot of that too, especially younger patients, to be honest with you. And it is to me it puzzles me. I can't understand. I don't even know what questions to ask to try to understand why is that. Sai, I wanted to go back to something you said. If you could just share with us a little bit more. So these prescriptions that you mentioned with like 15 drugs, are they being given like for mild COVID before they come to the hospital, or are they being given like as soon as people need the hospital?
No, it's all almost all telemedicine based and some in person, because the volume is so much that, and I guess patients want these things. So they're giving them standardized, most of them are vitamins, and then maybe ivermectin, an antibiotic, favipiravir, depending on the situation. Unfortunately, some are actually even giving steroids early, and we're kind of reaping the sad part of that now with the mucor and the infections. And so we're doing our best to educate people who are, just doing this to kind of not do that. But the vast majority have now, I think the last 3 weeks, have realized that the simpler the regimen, the better, because they're getting a lot of feedback from patients that, these aren't working, what do we do? And the oxygen kind of crunch that happened has also put people to try other things. I mean, people are, I saw this video about using a fan to get oxygen, and it spreads on, like wildfire. So one of the things to really do is to kind of get rid of the misinformation and remind people that, there is science in all this. There are scientific things. And as pulmonary physicians and critical care physicians, part of our role is going to be outside the ICU to educate people what you need to do to stay out of the ICU. And that's, I would call, the public health aspect of critical care. And I think it's very important we do that, because you see the sickest patients and they consume so much of resources. And if there's a way to prevent it, I think we should do that. And so I do that anytime I see people that steroids started early, do our best to stop it. And some people don't tell you, like family members, so know that, hey, he's like not going to let us take these drugs. So I saw somebody's WBC count. They say, what is 14,000? And you're only day 2 of the illness. What did you take? They confessed, we took steroids. So those kind of things happen. So I think it's important to remind people that the simple things still work. Most people do well. And when you don't do well, there is enough expertise available to kind of talk about it. And you're not going this alone. You can actually get advice from, people like Alice and Stefano and Tom and Marina and say, hey, what did you see? So I was actually curious, Marina, how was the Brazil surge? Because I honestly, I looked at the headlines, but I didn't go into it because I was like, I don't want to read the bad stuff. But now I'm like, these guys went through it. What can we learn from them? So how did you guys do your days? I'm sure you had very long days and managing so many patients. Any tips you can give people in the middle of the surge now?
Yeah, well, it was a little bit disappointing actually, because we Well, I could say quite well. When we have the first surge last year, we had time because we have seen what happened to Italy. So the hospital I work was lucky because they had just finished a building that were going to be our new ICU. And then instead of just moving the ICU, we kept both ICUs. So we have the old one for COVID-free patients and the new building for COVID patients. So he got 100 beds that was ready when the pandemic came. So I guess we thought like, oh, we did okay last year. This year will be okay. And that was not really okay. It was really, really sad. And we had to, what really changed for me is that I went to the emergency room. We did rounds with physicians in the emergency rooms because we had like 30 patients mechanical ventilated in the emergency room, and we didn't have place for them in the ICU. So they really didn't have experience. We had to train nurses and physicians for prone position in the emergency ICU, in the emergency room. That was really, really difficult. They have a very different way of thinking from intensivists, I guess, because they treat the immediate problem. They don't think ahead what's going to happen from 2-3 days a week from them. So the patient had a new fever. They said, oh, perhaps I should start an antibiotic. So we have to change a little bit the way they work. So that was the most challenge for me. It was working with people that was not used to work in the ICU, because as I said, I work in a university hospital, so I'm a little bit lucky. It's different from other hospitals in Brazil that they already have non-intensivists working in the ICU. We had only intensivists in our ICU, but then we had ICU outside of the ICU. That's what's really different. And also we had anesthesiologists coming to the ICU. They had a whole unit that was managed by them. And here in Brazil, we have a different, it's not the same path. Right? You don't do anesthesiology as a part of being an intensivist. You can do it, but most of us didn't do it. So they really also didn't have the way they thought. It was very, very different. But they enjoyed, they learned, and we learned. We had a very good exchange of knowledge. But I guess the worst part was, for the first time, we didn't have enough ICU beds. We didn't have, in some parts of Brazil, not here in the south, but in the north of Brazil, we didn't have enough oxygen. It was really sad because really people died because the hospital went out of oxygen. They didn't have enough ventilator here. Our problem was mainly we couldn't get patients transferred to the ICU, so they had to have their care not in the optimal place.
And just to add, Marina, please correct me if I'm wrong, but Sai, in our hometown, Marina and I are from the same hometown. In our hometown, 3 of the hospitals actually had to close their ED. We have 5 big hospitals, but 3 of them had to close the ED to then house ICU patients to become an ICU. So things like MIs and strokes that would get TPA easily or go to the cath lab easily, they were not getting the care that was standard until this big surge in COVID hit.
I would say that almost every hospital at some point closed their emergency doors. Not at the same time, but all at some point they said we can't receive any more patients. And one is it's the one that Alice did her internal medicine residence here. because it's known for not close the door. They always find room for one more patient. So that really scared the population when they saw that that hospital closed its door and they said, yeah, we don't have place for no patient now. Then people got scared. I guess that was scary. And when we had a private hospital saying that they couldn't store their deaths anymore, that they needed a truck for doing that, that was something that really touched the population here in Porto Alegre, because I guess this also helped to reduce the case, because for the first time we saw people that they started doing the prevention measures like social distance, mask wearing. That's really scared everybody.
And I think also that's important to point out that I believe, at least in terms more of a cultural thing, things that Indians, Italians, and Brazilians have in common is that we do not understand being apart. I think that that's something like, and please correct me if I'm wrong. I see Sai was laughing, and I think that that's an agreement. And Stefano, I'm not sure, but for my family in Brazil, they couldn't understand, like, what do you mean we can't see each other? I'm like, yeah, you cannot see each other. Like, that's what it is. So I think that's part of what it was hard also. And I think that's part of why all these countries were hit really hard at the same time. Because it was like in Brazil, for example, things got really worse after Carnival, because people could not understand that, like, we're still in a pandemic. You cannot go to Carnival. So it's hard. I feel like there are things we have in common, the three countries that we have represented here today, that in the US, I feel like it's easier to understand. And I feel like that part was a little easier to have people understand, like, you need to not see everybody. I think was a little easier, but unfortunately, we are running out of time. This conversation has been amazing. I wish we had 3 hours to keep talking to each other. So as a parting gift for our CHEST members, I would like that each of you to give a pearl about, is this new COVID, or is the same old, we just got better, or the disease got a little stronger than what we could predict? And what is something, if you can share one pearl of what you learned during this year and a half that we have been dealing with this infection, I would really appreciate if you could do that for our CHEST members. And on behalf of CHEST, I really want to thank you all for joining me this morning, evening, afternoon, whatever you're calling from. And thank you so much for all you do. Thank you for taking care of our patients. And thank you so much for sharing your knowledge with our CHEST members. So I'm just going to call Marina first, because she's first in my screen, and then please go after her.
Well, I think it's the same disease. I really believe we're getting better and we are improving our knowledge. And what's the second thing?
A pearl, like something that you learned that you want our CHEST members to learn from you. One pearl.
Yeah, I think prevention works. Everything we know about prevention works. Vaccines, mask wearing, and social distance works. So that's my pearl.
I can go next. I think, yeah, I mean, this feels like the same COVID. You know, I don't think this is anything new. I think we're better at treating it. I think we're better at organizing intensive care around it, and better at preventing it, or understanding how to prevent it, whether we actually try to or not. In terms of a pearl, you know, I think COVID is critical care, right? It is critical care 101. It's what we do every day, but at a much larger scale. And so I think it highlights the moral distress and the impact on clinicians, right? Like, this is what we do every day times like 1 million. So it takes a toll on physicians, nurses, respiratory therapists, everyone. And so I think it really highlights the need to create structures that prevent burnout and ensure that we can maintain this workforce going forward.
So I go. So I think that I agree with Thomas. Is the same disease. The point is that it's evolving a little bit different now because of several factors. But in terms of pearls, I think that I got two of them. First one is still we need to improve our knowledge on pathophysiology of this disease because it's not clear enough to us. So we need more data from animal models, from pathophysiological point of view, to really understand this. And the second pearl is enroll your patient in randomized controlled trials because we need very good data. And these are the only way we can survive from this epidemic. And this is the two things I would like to share with you.
So I think this is the same disease. We're just seeing it in just larger volumes and the complications are many. So the challenges are more and we're just needing to think on our feet. It's a huge opportunity for us to educate our colleagues who are not in critical care on how to manage critical care very effectively. And in terms of pearls, I mean, pearls are under the ocean and waves are on top of the ocean. So I don't want waves of pearls at this point. So I'm just going to say I would just recommend stick to wearing a mask, getting vaccinated, and completely agree with Stefano about the research needs. And it'll be very important for people to think about the global experiments happening right now and see what can be derived from it. And I think also to remember that, we're all going through this. I'm sure all of your family has gone through this and we've had our own challenges, heading home, heading to work. I mean, like you're on a spacesuit and airlock spacesuit kind of a situation. So it's probably important for us to also remember to kind of look at each other as human beings and not forget that kindness, compassion still have a huge role to play because ultimately comfort always, right? That's our goal. So I think even though it's all unknown, we need to reassure our patients that we are still there for them, whatever the outcome.
I love that. Let's all give ourselves some grace and let's hope we can bring those hugs back really soon because I'm missing them. Thank you again so much for being with us today. Really appreciate you and thank you all so much for what you're doing for all our patients.